Yeah, will be fine.
Good evening, everyone. Welcome to all of you for this third episode of Clinical Masterclass by Initiative for Sleep, Asthma and Allergy Sciences, ISAS. As you understand that we have already initiated this very important initiative in which we are going to have some case discussions by the experts. So today's theme will be atopic dermatitis. And you know that for atopic dermatitis, we cannot find any better person in the country than Dr. Deepti Pujari. So Dr. Deepti Pujari is the senior consultant allergy specialist at Dinanath Mangeshkar Hospital at Pune. And simultaneously, she is also doing a lot of allergy practice in pediatrics as well as in adults at her own clinic at Pune. And she is having a lot and lot experience, especially on the skin allergies, whether it is urticarias, angioedemas, or any type of dermatitis, atopic or chronic dermatitis. And she has helped us a lot at different platforms related to all these skin conditions. And today, once again, we would like to invite ma'am for a case-based approach or a case-based discussion on atopic dermatitis. Ma'am, thank you so much for accepting our invitation. Welcome you.
Thank you, Dr. Neeraj Gupta, for having me. I really thank you from the bottom of the heart, the whole team, Dr. Mitesh, Dr. Krishna Mohan, Dr. Kalyani and Vikram, all of you for inviting me here. So can I start sharing, Dr. Neeraj?
Yes, ma'am. Please share.
So let me make it full screen. Is it full screen now?
Yes, ma'am. It is full screen. You can start now.
Okay. So, good evening, everyone, and I thank you once again, Dr. Neeraj Gupta, for having me here. It's a real honor to be speaking on your platform. I hope I do the justice. Please feel free to interrupt me. I'll try and finish off in 40 minutes, and then we'll go from there. So, today, Dr. Neeraj had told me to speak case wise. So, I thought I'll do some varied presentations and we'll see how we approach. Okay, so I'm going to try and deal various case scenarios and we'll see can we think something differently. So, we'll not go into details of atopic dermatitis just for touching up. It's also called eczema. It's inflammatory, chronically relapsing, non-contagious, and extremely pruritic skin disease. Every word is important because that's how you manage the disease. And the symptoms may vary depending upon how good or how bad the condition is: dry, scaly skin, itchy, redness, oozing, crusting, thickened or scaly skin, darkened and lichenified, depending upon how good or bad the condition is. And we all know it is due to leaky skin barrier. There are so many causes, but this is considered really a big one. There is filaggrin gene defect. So the cells, there is a gap in between the cells of corneum, stratum, and so it is quite leaky. Moisture goes out, something comes in. Whatever goes inside the skin, a child can be allergic to those items. And it is multifactorial. There is a strong interplay between immune dysfunction, barrier dysfunction, and environmental factors. So it is a multifactorial. There is not one-to-one causal relationship. Okay. And diagnosis is clinical because there is age-wide distribution. Morphological picture is very specific. First it is external, then it becomes towards the flexural surface, and then as the child grows in adolescent period, it again becomes extensor and flexural with lot of lichenification. So no tests are required, no fancy anything is required. Clinically you can diagnose it very well. Okay, but as I present the cases, we'll see where can we stuck up. So this is an old case. I have presented it earlier, but I thought I'll present it again because I feel it's very, very important. This is how we are going to face our cases in our clinical practice. A 5-month-old child born to non-consanguineous parents, full-term C-section, complains rash all over the body on and off since the age of 3 months. 3 months is important. As we go ahead, I'll tell you why everything is important. It was very itchy, mostly present on most of the days. Distribution was face, chest, extensor surface. As I said, in infants, it's mostly extensor rash. Family history, father had eczema. Okay, so the diagnosis is very clear. You can see the face, extensor surface of upper limb, lower limb. It's all scaly, itchy, rash, which is suggesting that it's a clear cut case of atopic dermatitis, and the age of onset is also very typical. So we all know Hannafin and Rechka's criteria. Almost 4 out of 4 are present here. So no test required, nothing to go about. We have to give proper skin care, good moisturizer, good advice, good family counseling, full diet, and the child, once you do this, the child will improve. So this is a typical case scenario, typical atopic dermatitis, typical age of onset, typical progression, responding very well to your skin moisturizers. Okay, so now let's go ahead. The child was fine till the age of 13 months, but started worsening of eczema since last 2 to 3 months. That means around 12, 13 months of age. Weaning was started at the age of 7 months, was on rice, all types of dals, wheat, oat, ragi foods. A typical Indian household meal was given to this child, also on cow's milk, eggs, chicken. So everything was introduced properly and he was having a good family plate. But this is his condition when he arrived at 13 months of age, had condition had worsened, and as you can see on his the lower limb, it has even become flexural now. The whole of abdomen is covered with rash. Mother stopped child's cow's milk at 8 months of age because someone said cow's milk is causing this rash. But the eczema worsened. So remember, friends, in clinical practice also, if we are suspecting a food allergy, we stop that food item. The child's condition should definitely improve. But nothing of this sort happened here. The condition worsened, was prescribed 7 to 10 days of topical steroids intermittently on and off, but the rash would ooze and everyone was having sleepless nights. On proper history, child was given masoor and basin massage several times during first 6 months of life. So now on my very first slide, I said what it's a leaky barrier. There is gap in the cells. So moisture goes out, but something comes in. So whatever you apply on the skin comes in and the child can get sensitized to it. Sensitization is okay, but what did the mother said the child has started flaring up. The child's condition was not coming under control as it was initially when the child was on breast milk. And cow's milk was stopped, that also didn't work. So something was definitely going wrong, and mother was hell bent that some food items are increasing his symptoms. So we did skin prick test, and of course, masoor and besan came positive. Rest everything was fine. Now, SPT definitely correlated with the history because child had several massages on the skin with besan and masoor dals. Mostly, we will not avoid food items which are just sensitized. But here, with proper skin prick test showing positivity, and mother is saying she was not very much sure what is flaring, but they were using masoor dal and besan routinely in their food items. And then mother realized, yes, whenever she had given these items to the baby, the flare-ups were more. So with this skin prick test and history correlating, every time mother giving some besan items or masoor items and the child is having increased rash, we thought it is one-to-one correlation. We stopped these two items. We asked the child to follow up. The skincare regime was given and child definitely improved. So here, what we have done, we didn't do a big panel. Whatever the mother was giving, we did only those. Whatever we were quite, the family history or the past history was suggestive of something going wrong on the skin. We did that, and two were positive. It was clinically correlating, and that's why we stopped these two items and the child improved. Okay. If you are unable to do your skin prick test, you can go for serum specific IG by immunocap method with proper history. No need to do those big food panels. Okay. So this is how this child improved. Okay. Now let's come. So again, this is a very typical case. Child doing very well, and suddenly he might show some flare-ups. Mother sometimes they tell us every time he eat peanuts only, then he's showing flare-up. You have to stop that food item for say 6 months, 1 year. You can repeat the test. You can do food challenges. Food challenge is a must actually, but the child was small here, 13 months. Mother was not ready to do. There was clear cut history, so we didn't go ahead to do food challenge, and we just thought okay, and the child improved dramatically, the skin got cleared, okay, and rest all the food items were continued, even the milk was reintroduced, and the child was absolutely fine. Okay, so this is how you will clinically diagnose and follow up your patients and manage your patients in your routine day-to-day clinical practice. Okay, let's move ahead. This 13-year-old boy complains of severe eczema flare-ups with oozing. He's 13-year-old, still he's having intermittent flare-ups. History of high temperatures on and off since childhood. So here is a caveat. There is high temperature. There is no need for temperature to come in a case of eczema. Okay. It has no business. But this child had history of severe eczema since birth, not fully controlled. Since birth. Again, whatever I have highlighted, they carry a meaning. Here there was severe eczema since birth. Okay. Eczema normally in a normal atopic dermatitis comes mostly after 2 months. Here it was since birth. Treated with topical steroid multiple times. History of repeated skin infections since early life. Okay. History of repeated skin abscesses. Incision and drainage was done 4-5 times for pus drainage. Okay. History of diagnosed staph pneumonia at 9 years of age, and history of father had recurrent skin infections since child. So definitely this was not a typical case of atopic dermatitis. Some red flags were there, so we had to think something different. And this is how severe oozing, crusting, itching, swelling, incision and drainage done, and no matter what we did, it would never come under control. Okay, sometimes or the other there were flare-ups with severe high temperature and superadded infections. In view of repeated infection and severe eczema, immunological workup was done. Eosinophilia was very high, HIV was negative, IgG, Ig, IgM were normal, but Ig was very high. The report just said more than 6,000. The machine could not read more than that. Okay. Father's Ig was tested. That was also very high. In view of the above history, examination, and investigations heard, the diagnosis was hyper IgE syndrome, that is, Job syndrome was done. So, here, what I'm trying to say, you need not diagnose Job syndrome, but definitely here you need to investigate the child. We might not know all the syndromes, even I don't know. We have to have our colleagues involved, our immunological colleagues, rheumatological or infectious disease people, we have to involve all of them, our geneticists in the hospital, and we need to investigate these cases ahead. Such high Ig definitely is not routine. Such high eosinophilia definitely is not routine with father's Ig high. So it was a case of hyper Ig syndrome. And this is what I have shown here. Total eosinophilia is high and so on. So what are the syndromes? Hyper Ig syndrome, Netherton syndrome, Omen syndrome, Viscott-Eldridge syndrome. And I thought I'll just complete the list. It is endless. That's exactly what I said. We are not even supposed to know all this. But why I'm presenting these cases, I'm trying today to sensitize everyone, the whole audience, about the varied presentation and how we should think. What are the red flags? So it could be anything from, polyendocrinopathy, X-linked, STAT-B deficiency, Omen syndrome, even atypical complete disorders and metabolic disorders, multiple carboxylase deficiency. So many things can present with atopic dermatitis. So what I want to say is, if atopic dermatitis is coming with repeated infections, repeated abscesses, pneumonias, osteomyelitis, there are some atypical facial features, please think out of the box. You could be dealing with one of the immunodeficiency syndromes. You have to go read, do investigate, do IG immunoglobulin profile, all the blood profiles in. You can involve your colleagues, and you need to get to the bottom of the disease. So, a quick word on hyper IG syndrome, because I think we are seeing quite a few now that we know. We only see what our brain knows. So, it is definitely it's a primary immunodeficiency. There is STAT3 or DOC8 deficiency. One is autosomal dominant, one is recessive. The dominant one has more immune dysfunctions and connective tissue abnormalities, whereas the recessive one has more of allergies, viral infections, and skeletal issues. And there are other mutations as well. But STAT3 and DOC8 mutations are very common. One is autosomal dominant and recessive. And clinical findings are also very typical. Skin has cold abscesses, meaning what? You'll have to look for it. The abscess won't be, red, inflamed, and, shouting at you. It would be just a cold abscess, okay, with severe chronic eczema, not coming under control, oozing and crusting all the time. Then recurrent pneumonias, because and they tend to form pneumatoceles, and bronchiectasis is very common because staph and pseudomonas infection is common, and they end up with bronchiectasis and pneumatoceles. Okay. Facial abnormalities. They have typical facial features: prominent forehead, chin, deep set eyes, broad nose, retained primary teeth. Even I didn't ask that history because I was not even thinking. I didn't know that. Hyperflexibility of the joints, frequent fractures. And then once you do your immune profile, you come to know your IG is very high. And for the diagnosis, actually, IG more than 1000 international per ml is also considered a criteria. So these important features would be present in many of the immunodeficiency syndromes with your atopic dermatitis. And how do you manage such patients? So you have to do their workup, you have to do their genetic testing, you have to come to a conclusion, and then depending upon what is the condition, you might have to treat them differently. Like in job syndrome, you will have to put them in lifelong antibiotic prophylaxis, okay? Because staph infections are rampant, including skin, including your bones and lungs. They end up with pneumatoceles and bronchiectasis. So yes, they need good antibiotic coverage. Okay. Whereas our normal severe atopic dermatitis don't need that. Skincare, aggressive skincare with everything possible. Okay. Advanced treatment, homeopathic stem cell transplant, sometimes considered in DOCAT deficient forms. So as I said, you will have to involve your hematological colleagues, your immunological people, geneticists. Everyone needs to come and work together in such cases. Okay. Now, how do you know that this is a syndrome or it's a severe atopic dermatitis? So I thought I'll keep this slide. In severe atopic dermatitis, the disease occurs during the first year of life, but often after 2 months. And all your syndromes, they start since birth. Mother gives this history. Uh, पैदा होते ही rash थी. Okay. So this history you typically get in your syndromes. Okay. There are variations, but I'm giving you a generalized statement. And mostly our atopics, they develop after 2 months, 3, 4, 5, 6 months. Okay. Patients with severe atopic dermatitis can also exhibit increased IG and eosinophilia. We all know our atopics have high IG, but the syndromic varieties have very, very, very high IGs. Okay, they can be 20, 30, 40,000. Okay. Cutaneous infections can be secondary infections in atopic dermatitis. There could be staph infection. There could be eczema herpeticum. But then what is the difference? Once in a while, they get the staphylococcus infection. Once in a while, they'll get eczema herpeticum. You give them the bleach baths for 4 to 6 weeks, their skin just clears out. They won't have so deep-seated infections, pneumatoceles and bone infections, okay? Or severe cold abscesses that you want long-term antibiotic. Once in a while, here and there, severe atopics do get infections. But this is how you'll have to think. You'll have to ask them to give you proper follow-up, and then you'll have to decide whether you want to work up something extra or not. Okay. So this is the difference between syndromic variety and severe atopic dermatitis. Okay. So, as I said, red flags, early onset, prior to 2 months, your antennae should go high. Recurrent, severe viral, bacterial, and fungal infections, presence of other affected family members. Again, atopic itself is, dermatitis itself is a genetic condition, but your syndromic varieties are mostly autosomal dominant and recessive or X-linked. So, a good history will guide you whether others are showing similar symptoms. Okay. And definitely, as I said, skeletal abnormalities, other immunological abnormalities, typical facies, hyperflexibility of joints, all these things you'll have to keep in mind. Okay. Now let's see one more interesting case. This 13-month-old male child, I have given his name Bob. Very recent case, just last 20 days back. Severe atopic dermatitis since 9 months of age. Okay. 9 months of age. Mother feels the disease is worsened in last 2 months and mother is not giving any weaning foods to the child now. Mother thinks whatever the child is eating, the condition is getting worsened. The condition is never coming under control. She is steroid phobic. Whatever the doctor had told, she has not been using. So she came to me because the child had started losing weight and she said, my child is allergic to everything. I want to get tested on repeated history, on history. She said, no, she'll not give anything unless it's proven that the child is not allergic. She was so scared. Okay. The reason being, look at the rash. The child, and the bad part is this is after little bit of improvement. The child was so bad when he was brought that even I forgot to take the pictures. This is after 3-4 days of treatment. I told her to send me the pictures. So can you see the boils? They were pus filled, red, inflamed. Even I was worried when I first saw this child. Immediately before doing anything, I don't know, the forum here today might say it, I did wrong, but I put this child on oral antibiotic, coamoxiclav and oral acyclovir. That's what I did because I was in no mood to put more steroid on boils that were red, inflamed. I thought they were pus filled. It was scary. I thought I might lose this child if something goes wrong because such children, the skin is already broken. Your infections can quickly go deep seated. Just 13-month-old child and can end up in big trouble. So I started this child immediately on oral coamoxiclav, oral acyclovir. Okay, we get that syrup. And in 3 days, the mother sends me these pictures that the child has definitely improved, but still the lesions were there. We told them to take all the precautionary measures, gave proper skin care, moisturizer, steroid, everything was then subsequently done. But as I said, mother was hell bound to do allergy tests. So in such cases where nothing was sure, I went ahead and did component resolved diagnosis. And look at this. Everything was bang normal. Okay. So I have just put this 0.45 macadamia is absolutely insignificant. She had never in her life given macadamia. And so was egg white, 0.36 and 0.32, very insignificant because again, mother had never introduced egg. Then why is it positive? Because this is a very, very sensitive test. The child must be sensitized because there are egg fumes and there are so many, macadamia allergens could be there in the air. It penetrates and the sensitization pattern was caught up in this test. But rest all everything came negative. Okay, so I've put other food charts, everything is negative. And look here, total IG is just 195. Okay, very less. With such severe lesions, I was expecting a high IG. So now you have to start thinking which are the conditions where the IG will be high. So a very good clue here, lot of infection. more than, inflamed red skin of typical atopic dermatitis. When the child, as I told you, the first thing I did, I started on oral antibiotics and oral antiviral. Okay. So this is definitely something different than our routine atopic. Okay. And so did the blood picture showed the same thing. No food allergies, absolutely. Even IG is not raised. The infection pattern was definitely more, and child responded so well to antibiotics, the skin cleared. And then I told mother to apply proper steroid and full regime, good counseling, moisturizer, everything were prescribed. And I've asked them to follow up. They came, one follow up was given. And as I said, this child was very recent. In next 2 days of this child, I got another child. The first one I named Bob, and this 9-month-old female, I called her Bobby. Okay. Severe atopic dermatitis. I thought, I don't know why I'm seeing these atopics in this such hot summer season. But yes, they were there. This child had a history of atopic dermatitis since she was 3.5, 4 months. That child developed it at the age of 9 months, and he was 13 months old. She is 9 months old, developed all these symptoms since she was 3.5, 4 months of age. Okay. Mother feels disease is worsened in last 2 months, and very typically, like that mother, this mother also was not giving this child anything to eat. Again, I had to counsel, but she was so scary because this child had not slept for the last 10 to 15 days, neither had the family. Can you see this first picture? I hope it is clear. Huge rash, the skin, everything is red. It is absolutely red. There was not a, you know, point on the skin where there was no rash, extremely itchy. The child was irritable, crying. Parents were depressed. Mother had stopped giving her all the foods, and this was a miserable child. I asked some history. Mother definitely said that she had given some massage basin or some massage and the child, but the child showed severe flare ups, so she stopped. Breast milk was given, bottle feeding was given, but just now the mother was scared to death to give anything. Again, this child had a rash typical of atopic dermatitis, extensive, so you can call it a SAD, severe atopic dermatitis, but didn't have any boils like the previous child. Okay, so here I gave proper steroid moisturizer, all the regime was explained, and we went ahead. But again, the mother was hell bent. She wanted some allergy test to see what the child is allergic. Even I was afraid because it was extensive all over the body. This we did ahead again and did component resolved diagnosis, and look at the report. Two similar kids, similar age, but look at this child. Extensive allergies. Okay. So all the legumes, the peanuts, chickpeas, soy, lentil, peas, everything, grains, including oats and quinoa and barley, wheat, everything is positive. Okay. So then I asked the history, and mother was very sure that half of these things she has not even tried on the baby. Correct. That's exactly what I wanted. So that's what I want to give you the message. Component resolved diagnosis is not a diagnostic test. Again, it is same as your skin prick test, same as your serum specific IG, just it does components. This coming positive in no way means that child is allergic to these. Again, this only shows sensitization. No matter what you are seeing, the red ones, grade 3, no, doesn't matter. You have to correlate it clinically, and ideally, if you want, you have to give oral challenge for these food substances. Going ahead, this child was allergic to, again, sensitized to so many things. You look at the nuts, everything possible. So, all albumin globulins, can you see? All your globulin, albumin, they are all cross-reacting with each other. Here, again, some PR10s are there, but mostly albumin, globulin. So, uh, we'll not go into the details of component resolved diagnosis because that's not my topic today. But yes, this child was definitely sensitized to lot of food items. Okay. Again, I repeat, that doesn't mean that she was allergic to all. So what do you do in such cases? Eggs. Look at the value of the egg that was positive. Mother was very sure that she was giving egg to the baby, and this was definitely one thing that was strongly positive. And even ovomucoid GLD1, which is quite heat resistant, that was strongly positive. So that's what I thought, we should stop her eggs, because mother, then going back to the history, mother did say that whenever she was giving egg, yes, the flare ups were more. So this is one item which I stopped. Rest, none of the items we stopped, because remember, what does the LEAP study say? Earlier introduction is better. So you cannot avoid these foods. In fact, you have to ask the mother to continue. This child needs a very close follow up. Here you will advise, don't give all the food items at one go, so that you are also confused. I am confused which one is causing what. Ideally, what I wanted is one food item for at least 5 to 6 days. The mother should continue with proper skin care, which whatever I had told, so that even she's confident, I'm confident, and we know which of these is really causing flare ups. Okay, so just these coming positive in no way means we should stop these food items. In fact, we should continue giving them unless we are very sure something is causing severe flare up, because if we stop them, then the child might show up real allergies when we introduce these foods later on in life. Okay, so we continued all these. So, and rest everything was negative. And look here, total IG sky high. So this machine, it is semi-quantitative when total IG comes. So it doesn't give exact value, but it was so high, 2500 is the upper limit for this machine, and the result shows more than 2500. Okay. Which shows here the total IG was very high, and she had so many positive, made total sense to me. Okay. So other than egg, which I reconfirmed 5 times with mother. Yes, she was showing some flare ups with it. Rest everything we continue. Okay. So now I was thinking that let's see, can we think differently in these two cases? So my Bob, the 13-month-old male child with low IG, started having symptoms of atopic dermatitis at 9 months of age. And my Bobby, who is now 9 months old with high IG, very high IG, started the symptoms at 4 months of age. I thought, let me compare how these two are different. And and these are very recent cases, huh? Just 15-20 days back. So I'm still working on them. Both had C-section. Again, C-section is one point which goes in favor of atopic dermatitis, because your body is not exposed to the natural vaginal microbiota. Okay. Both had exclusive breast milk, but Bob's mother still continues to breastfeed this Bob, and now he's 13 months old. Exclusive breast milk was given for 6 months. So this, again, I reiterate, breast milk is considered one of the best medicines to prevent atopic dermatitis. It has all your natural IgAs, natural microbiota, which are protecting oneself from atopic dermatitis. Okay. So this definitely I saw positive, and this mother unfortunately had to start bottle feeds at the age of 3 months, because she thought she was not getting enough milk. Okay. Bob's mother only did coconut oil massage. This mother mostly did coconut, but tried besan thrice, almond oil 7 times, desi ghee twice, and sesame and some olive oil. And she definitely feels that had severe flare-ups on applying besan. Rest she cannot correlate, because she said that the child's skin was never normal. So I don't know. But with besan, she immediately saw red flare ups, and then she stopped everything. It is known that giving antibiotics in the first year of life increases the chances of atopic dermatitis, because you are losing your natural microbiota of the gut. Bob didn't receive any, and Bobby did receive once. That's not too much, but I'm giving you the real history, whatever I got from the parents. Age of weaning was after 6 months, exclusively breast milk for 6 months in Bob. And this child, Bobby, got bottle feeding plus the weaning was started at 5.5. One thing that goes again, see, now Leap study says you should start giving all the foods, but this mother was not giving too many foods, very minimal solids, mostly rice, dals, and fruits. But Bobby's mother had tried almost everything, everything. Oh, never given eggs, no, she was giving eggs. This mother, Bob's mother, had never given eggs. Bobby's mother was in fact giving eggs, she was giving nuts, she was, so this is a misprint, I'll correct it. And she was giving almost everything. Okay. Ideally, joint family is good because hygiene hypothesis says in joint family there is not too much of hygiene, so your Th1 is more prominent in such. But nothing of this was observed. One was nuclear, one was joint, and there were no pets at home. This is the data which I got from both the mothers, and so I have put it as I got. So now my question is, can we think when the patients come to us, can we think something ahead? Can we think who will develop food allergies? By any chance, let's see. I tried to figure out. So what answers I got? Skin barrier, nothing great, but I thought I'll quickly revise whatever I could figure out. Increased transepidermal water loss at birth. In fact, Dr. Vedantan has even given the numbers more than 36 nanograms per ml, more than, between 25 to 36, less than 15. Some figures he has given. Water loss, transepidermal water loss is one of the biggest markers which tells you about your skin barrier dysfunction. Okay. And it has been linked to higher risk of developing atopic dermatitis with food allergy. Now we are trying to see how can we predict, when the child comes, can we predict that this child could be having a lot of food allergies or sensitization? Dual allergen exposure hypothesis, we all know in an infant's skin is exposed to food allergens before the gut develops tolerance. Okay. Through oral consumption, they may develop. But in our case, she had given oral foods. Bobby's mother had given oral foods. But the thing is, she had given a lot of massages. So, what I feel, her skin sensitization was prior to the gut sensitization. Okay. Dual allergen exposure hypothesis says your gut should be first because whatever goes through the gut, your T Rex cells develop, but whatever comes through the skin or directly is inhaled, your Th2 cell line gets activated. So we want gut first and then the skin and then. Bobby's mother did give all the food on time, but the massages were so many that I feel the skin had lot of breakages and lot of sensitization happened via skin. Forget the massage. You don't have to massage also. It all depends how bad the skin was and what the fumes were in the house, how the skin care was taken, what all entered the skin. What else? Genetic. Nothing can be done about this. Genetic predisposition. Mutations in the skin barrier genes are associated with food allergies. Family history of eczema, asthma, and food allergies increases the risk. On going back, this Bobby's mother did say that the paternal grandmother had lot of skin issues, inflammation, redness, itching. They were not sure what it was, but this grandmother did have some issues. So genetic plays a lot of, a big role. Immune system dysregulation. In infants who develop food allergies, the immune system may perceive food allergens absorbed through the skin as invaders, leading to an allergic response. This can involve production of Ig antibodies and activation of cells like basophils and eosinophils. And that's exactly what we saw in Bobby's case. Okay. Environmental factors, early excessive use of antibiotics. Our Bobby did get one course of antibiotic. Okay, Bob didn't. Lack of exposure to allergens in early infancy can increase the risk of developing food allergies. Yes. Okay. Microbiome changes, very, very important. Alteration in the microbiome, dysbiosis. There was some dysbiosis in Bobby's case. Mother could not breastfeed exclusively for 6 months. There was C-section, lot of bottle feeding, lot of foods were, lot of massages were done, antibiotic was given. So there was definitely some microbial dysbiosis. Okay. This increases intestinal permeability, thought to influence immune health and may contribute to the rise of food allergies. And I've put some references, whichever the best references I thought, I've put them. So these are the chances these are the factors which will increase the chances of food allergy sensitization. I'm just trying to sensitize you, all of you, as well as me. We are trying to see, can we think clinically? Okay, when the patient comes in, who's going to develop what? Severity of AD. The studies have shown that the risk of food allergy increases with the severity of atopic dermatitis. Infants with early onset eczema within the first 6 months are at the highest risk. And definitely, Bobby's eczema started when she was 3.5, 4 months, as against Bob's eczema started when he was 9 months old. Okay, so definitely this was there, and there was severe, extensive inflammation. So definitely Bobby fulfilled this criteria as well. Elevated Ig levels and yes, higher serum total Ig. I have not even done their CBCs as of now. Higher serum total Ig levels and eosinophil counts are identified as risk factors for food allergens. And yes, Bobby had very high Ig, and Bob, who had no food sensitization, didn't have high Ig. Okay, so this criteria was also fulfilled. Other clinical scores, high SCORAD, high ERC, a lot of pruritus, sleep disturbances scores. All that means what? Any severe atopic dermatitis, the chances of food sensitization increases. Okay, fair enough. Okay, now let's think, can we predict who will develop not food allergies but skin infections? Can we predict that? Because our Bob presented like that. So disrupted skin barrier. Of course, we know. So this is not very specific, I thought, because everyone, all atopics have disrupted skin barrier. But infants with AD have increased transepidermal water loss, altered skin pH, and disrupted lipid distribution, making the skin more permeable and susceptible to pathogens. So very dry skin with lot of lipid disruption, altered skin pH. So for food allergies, I went through some articles. Altered skin pH and disturbed lipid distribution was more for entry of pathogens. Okay. Immune dysregulation, again, same thing, an imbalance of immune system, particularly Th2 dominant inflammatory response can suppress cutaneous innate immunity, further increasing susceptibility to infection. So your Th2 dominant, of course, we know it is a Th2 dominant inflammatory condition. Microbiome dysbiosis. This is the key to think who will develop skin infections rather than food sensitization. Again, alteration in skin microbiome. Okay. Heavy colonization of Staph aureus are major predisposing factors. The problem is it's very difficult to predict who will have this. So in Bob's case, this was not there. So he was not given lot of antibiotics. Only positive thing was there was C-section. He was exclusively breastfed. There were not too many different massages. He was a nuclear family. He was from a nuclear family. He had C-section, but other criterias I didn't find. So I still not very clear how will I predict. But these are some of the factors which I found when I was going through the journals. Scratching. Constant scratching can lead to skin damage, creating entry points for bacteria, virus. So it's a vicious cycle. Chick or hen, we don't know which came first. You scratch and you damage your skin, and there are more entry of bacteria, viruses, and fungi. Okay. Prevention and treatment strategies. So now that we know who will develop more, when there is more of dysbiosis in the microbiome, when there is pH dysregulation, more chances of infections. when there is a lot of, what we saw, other factors, high Ig count, extensive skin lesions, there are more chances of your food sensitization. What interventions can we do? Food intervention, breastfeeding for more than 6 months is the most important point given across all the articles. Okay, everyone said breastfeeding is the most important. If breastfeeding couldn't be done, then a 15-year follow-up study said that extensive casein hydrolysate formula for the first 4 months of life has significant preventive effects of atopic dermatitis, allergic asthma, and allergic rhinitis. That means you are giving extensively hydrolyzed formula. Okay, for the first 4 months, where breast milk is ideal. Okay. What else? This is what we all know now. It's almost beyond proven that early LEAP study said that early introduction of the food causes, and giving it continuously for the first 6 years definitely protected the child from developing food sensitization. Okay. In addition, large scale population based prospective studies showed that early introduction of cow's milk protein, when I say cow's milk protein, early introduction doesn't mean on day 1, day 2 of life. After 6 months, 6 months has to be exclusively breastfed. Okay. As a supplement to breastfeeding might promote tolerance, reducing the incidence of Ig mediated cow's milk protein allergy. So again, the LEAP study has made it clear early introduction through the gut, later exposure. Once the skin is sensitized, before the gut is sensitized, then the body takes it as an invader. Body starts considering it as a foreign particle, foreign protein, and the child develops allergies. Can skincare prevent atopic march? We don't know. But yes, that's the only thing that we have. And beyond doubt, we have to keep a good skin barrier function. So, good care of the skin has shown that to some extent we can prevent at least more damage, at least more sensitizations. Okay. Um, Development of skin barrier functions, birth till 2 months, they say, is the most crucial period. Okay, because this is the period of transition and adaptation. There is a huge contrast. The child, the infant was in wet, warm, lubricated worm mix in the womb, suddenly comes out in a cool, dry environment post utero. So, first 2 months are the key where at birth, whoever the neonatologist is attending the baby should tell about the good skin care, because that's where your skin is primed. Okay. Barrier construction, desquamation, antimicrobial defense, moisturizer, acidification, all are established in the first 2 months of age. Prediction of food, future allergen sensitization and onset of atopic dermatitis, way before the clinical onset, they say can be predicted at first 2 months of age if you think of all my previous slides. Okay. So once we did this, so we are just, here we are all predicting what. So I thought, can we definitely think in such cases when they come to us, can we think where everything has become so precise? It's all era of precision diagnosis, precision medicine. So why not biomarkers for atopic dermatitis? So I'm not going to go into the details, but I thought today we'll sensitize ourselves to the biomarkers. So, biomarkers, I thought we have not dealt. We only talk about phenotypes. What about endotyping? Okay, we only talk this in asthma. Why not in atopic dermatitis? So, biomarkers in atopic dermatitis fall in two categories. The first category comprises of biomarkers that are used to identify persons at risk of developing a disease, that is your screening biomarkers, patients with active disease, diagnostic biomarkers, disease recurrence or progression in patients who have the disease, prognostic biomarkers, and predictive biomarkers who will benefit when you give a therapy. So these are first set, and the second category include monitoring treatment effect. This is the key biomarker. Okay, the disease severity biomarkers. and possible side effects, the pharmacodynamics biomarkers. So once I started reading, it's too much beyond our, domain. Definitely we need to do a lot of work in this. So I thought I'll just put this one slide. I've given the reference. You all can go ahead and see it. There are so many biomarkers. Okay. So this is just one category overview of endotyping. So why just phenotype, skin barrier, pH, microbiome, and all this? Okay, we have done phenotyping. Why not do endotyping? So depending upon which biomarker is significant, whether it's intrinsic atopic dermatitis, where your Th17 and Th22 cytokine will be more, or your, CCL, your chemokines, cytokines, interleukin 4, 5, 13, 21, 31, 33, which is prominent, which is not. Because this endotyping will ultimately drive your future therapies. Now it is all about biologicals. Okay, I'm not even touching it. How do we decide which biological? Definitely only on endotyping. And once we start endotyping our atopic dermatitis patients, we can predict a lot of things for them, and definitely we can improve their journey. So, my conclusion is atopic dermatitis is currently moving towards an era of more targeted therapies. Okay. The application of biomarkers will result in better characterization and stratification of patients and allow better comparison of current and new treatments. Given the variety of upcoming treatments targeting specific cytokine pathways, it is important to stratify patients based on the most important immunologic drivers of atopic dermatitis, that is, their endotypes, rather to subgroup them based on their clinical phenotypes. That's what we are used to doing. But we are correct also in a way, because we don't have those biologicals. We don't have simple dupilumab just now in our country. So, we will reach there. Once we start doing, things will become cheaper in our country also. So I thought, because I have such varied cases, I'll sensitize. It's a big learning curve for me also, that we have lot of work to do. So final take home, AD can be severe debilitating condition for the entire family due to its relapsing nature. Proper history, clinical examination. Once you do this correctly, you are done. Only relevant tests based on the history. Okay, your skin prick test, total IG, serum specific IG. Sometimes you might want to go ahead and do your component resolved diagnostics also. Don't forget your syndromes. I have shown what are the red flags. Time has come that we start predicting the course of atopic dermatitis in our patients by taking detailed history. Biomarkers are the game changers in atopic dermatitis, but for now, good and prolonged skin care with proper guidance and counseling of the entire family is the key for successful management. Thank you. And thank you for giving me this opportunity.
Thank you so much, ma'am. I think wonderful session as always, and that has really generated a lot of curiosities among the attendees and simultaneously among myself. So you started with few cases, and I really liked the way you highlighted the importance of history taking, meticulous history taking, and which is actually the key or the fundamental principle of medicine. But what happens that when we all are bombarded with a lot of investigations by probably either the pharmaceutical companies or by our own colleagues or by even the patients per se, then at that particular time sometimes the history taking breaks a backseat. But you really highlighted a very you can say like fundamental principle. The key is the history taking with your examples of this masoor and basin, and means like application and correlating or trying to correlate it with the patient symptoms. So it is really really very important, and each and every patient is teaching us a new thing. Each and every time we also learn as we gradually see more and more patients and encounter more and more patients. Ma'am, a few things. So, like we understand, like for an example, type 1 hypersensitivity normally we understand that whenever the allergen exposure happen, then at that time the symptoms usually start within, you can say, like 2 hours. That means something like for an example, appearance of urticaria or appearance of something like a anaphylactic type of thing, or vomiting, or probably wheezing episodes, or sneezing. But do you really think that that also is true in atopic dermatitis? Why I am asking you? Because let's assume that a patient who is having a true typical type 1 hypersensitivity, let's say food allergy, and manifesting as atopic dermatitis. Now, when the patient is consuming that food, let's say peanut or milk or whatsoever food item it is, then do you really think that within 2 hours the atopic dermatitis or the eczematous lesions start flaring up because the milk is going in the GI tract, and then thereafter the response is coming and then the skin shows flare up? So I sometimes feel that this typical time period of the 2 hour probably is not sufficient enough for you can say like making or seeing the flaring up of the atopic dermatitis. What are your comments about that, ma'am?
Perfect. Very well thought, Dr. Neeraj. You know why? Because had it been that, our atopic dermatitis patients would have flared up with eczema, with urticarias. They would have
Yes,
flared up with asthma.
yes,
So there the pathology is totally different. It is not typical. That's why in atopic dermatitis, they say you have to do patch test also. Okay, because here the condition is, multifactorial. It's not one-to-one correlation. So so mostly you are totally correct. It's not that eating besan and you'll have a flare up. It's not. If it was that simple, we would have got very clear cut history and we wouldn't have, had this discussion. So yes, it is not typical IgE. It is sensitization through skin. When we say typical IgE, it's mostly aeroallergen or food allergens we are talking about, and everything that is going via the gut. Here it is not the case. Here it is going by the skin and it is causing inflammation. So here the problem is not IgE mediated. Here the problem is interleukin 4, 5, 13, interleukin 31, 33. They are causing your pruritus. Okay, your
absolutely.
phosphodiesterase, your cyclic AMPs, your cytokines, your chemokines, CCL2, CCL6, they are causing problems. So here the
Absolutely.
pathogenesis itself is totally different. Correct.
Absolutely.
That's why you are seeing this difference.
And ma'am, that actually highlights the importance of like many a times, even if we take a very careful history, but sometimes even we also face difficulties and challenges because we feel that there is a multi-cuisine type of a food. Like for an example, as you rightly mentioned, that everything is not absolutely IG mediated. There are certain other factors also. That means the atopic dermatitis flare or the eczema flare might happen probably 4 hours later, 6 hours later, or even on the
Correct.
next day also. But by that time, the patient might have taken some more food, some different food.
Correct.
So actually, it becomes really difficult to pinpoint that, okay, he has not taken only besan or probably masoor in last 24 hours. He has taken a number of other things also. Then it
Correct.
becomes really challenging and difficult. And then the difficulties increase when we find your third case like cross reactivity and multiple positives. Then at that time, it becomes really challenging. So that is why you rightly mentioned that component result diagnostic should be means like interpreted very carefully, and only after by the you can say like by the experts who are you can say like really understanding the things in deep for at least you can say like probably a decade of experience or so.
That is a
Because
very good message you gave, Dr. Neeraj. That is the message you should be giving because you know what? I have seen patients who bring the report. They said हमारे डॉक्टर ने ये टेस्ट करा ली पर उन्होंने बोला आप किसी को दिखवा दो ये रिपोर्ट. So people
yes,
are just rampantly doing CRDs and you know what? Looking at that report, they might end up stopping everything. That would
absolutely,
be disastrous. That would
yes,
be really bad. So
yes,
clear, very correct point you brought out. So you cannot
yes,
stop everything. You have to interpret it very carefully, see what is cross sensitization, what is sensitization. Patient has not been even given those foods. You cannot stop them.
correct. Ma'am, one thing I understand that you told now the time is moving towards precision medicine, and we have to really you can say move towards that. Even in the west there are now researches which are going on in different endotypes and phenotypes, but for us these are not there. But for us, like let's talk today 2026, what is your approach when a patient comes to you with atopic dermatitis? In your mind, how you approach? I understand with the limitations of whatsoever limitations are there with our circumstances, but still, how you approach a patient that okay, if this particular patient, I will give only the, you can say like the skin care, but no testing. In this particular patient, I will go with the testing, food only. In this particular patient, food plus probably dust mite, and then in this part, or and then I will go with only avoidance. And in this particular patient, I will also think about adding some immunotherapy. So I understand that there are endotypes, phenotypes are not, you can say like well defined here, but still we all are doing. You are also doing. Myself is also doing case to case selection. So can you give a little broad outline that okay, if these one or two factors are there, you think this way, you think this way, you think this way, so that we understand that right now also we are actually trying to follow precision medicine. Not everybody we are treating like same.
Yes, Dr. Neeraj, your question is also very intelligent. So, you know what? I'll tell you what I do practically.
You.
First and foremost, it all depends on what age are they coming. Okay. Not everyone will come at 6 months, 10 months, or 12 months. 9-year-old, 15-year-olds, 10-year-old girls, they do come with severe rash crying that they cannot attend the parties. That is their main problem. But at that age, the things are easier. You get a good history. So again, I have to be very truthful. First thing, I take a proper history. If the age is slightly bigger, I get a good history. They tell us, they very clearly tell us this child is full of eczema and she keeps sneezing, sneezing, sneezing. I know, yes, she has been sensitized to house dust mites, even though there is not one-to-one correlation with house dust mites are known to cause the flare-ups. I will only do that, and they'll say, no, she's eating everything, foods are not the same. They give you that history. Okay, so where in little older children, little educated family, first and foremost, good skincare first to improve their condition. If at all, what I do is total IG because it gives me a lot of information. I know there is a big thing, total IG is useless. Yes, it is useless, but still it gives you a lot of information. Am I dealing with some syndrome? Is it sky high? Is it okay? Is it low? If it is low, then is it intrinsic atopic dermatitis? I might start thinking. So total IG in atopic dermatitis, I do. And then in little older children, if I'm getting sneezing history, asthmatics, I'll mostly go for aeroallergens because these children, they won't sneeze after eating a food. It's not like that. They are doing it every day. Okay. And they'll tell you some food items that are flared. The problem comes with infants when all the new foods are being tried every time and you don't know. But believe me, you don't have to test them. I'll tell you why. They are showing flare ups, they are irritable, they are having a miserable time because proper skincare was never given to them. You sit with them, you write and tell them this is what you have to do. First this, for then that, steroid this much for this many weeks, and then follow up with that. You give them a proper skincare with full diet, and their skin condition improves. So you know that it was a not well maintained skin, not properly treated atopic dermatitis. Nothing to worry about. Once you give proper protocol how to deal with their skin, they improve. So then what? You'll not test them for anything, nothing, not at all. In spite of good skincare, in spite of doing everything, mother tells you suddenly child was fine, 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 and suddenly they had eaten this and showed a big flare up. It won't be sudden. Child could be eating chapatis every day, and then suddenly she says, Ki, once I stopped chapatis for 7 days because we had gone out and the child was better. You get some history, you get some clues. Only in such patients you'll do those particular skin prick tests. Again, skin prick test is good enough. It's good enough. Okay. Otherwise, you'll just leave. In my setup, I have still not done interleukin 4, 5, or 13. I have not done that. I still believe in good skincare, good history, sometimes skin prick test. As you saw in my cases where I was also stuck up, I did component resolved diagnosis with good interpretation. In adults, mostly I'll do nothing. Maybe total IG in adults, look for any other comorbidities. And sometimes I might even want to do aeroallergens if I'm getting good history in my adults, because by that time I'm even suspecting atopic march has taken place.
Absolutely agree, ma'am. Last question to you. Like in your third case, when you have shown egg sensitization, egg white, which was there. So many times, like I face this problem that yes, we have advised the parents that not to give egg to the child, and we have done everything. But my question is that should we also advise to all the other family members not to take egg or not to take that food item? Because if somebody else is taking egg at house, then egg is actually anyway coming in the home, and the transcutaneous sensitization is continuing even if the child is not fed with the egg, which is actually the oral route. So means like, how do you approach in your clinic or your cases in such a scenario?
100% bang on, Dr. Neeraj. This family, it was so easy to tell them that you don't bring eggs at home, because I told them so many items have come positive which you have not given to the baby. So, how that all the nuts and all are positive? Because they are in your atmosphere, you all are eating, you all are roasting, you all are boiling, and that's how it goes, it penetrates the skin. It was so easy for them. And definitely for these children, you have to tell the family to stop eating, because otherwise the management becomes very difficult, especially in such severe cases. When you know that severe atopic flare up is there with such high IG, with such high component resolved diagnosis, you'll have to tell them to stop bringing eggs. Definitely bang on.
Thank you, ma'am. Thank you so much. Now, we understand that allergies are increasing, and in India also, there are so many academic programs which are going on at different forum, and we are also trying to support as much as possible by whatsoever way we can do. So we have started this initiative called ISAS, which is Initiative for Sleep, Asthma, and Allergy Sciences. And you all are aware that we have started with the first course, which is Master Course in Allergy and Immunotherapy. Now I'm going to announce something new. So the new thing is that everybody is aware, even Dr. Deepti ma'am has also undergone through the exam. This is European Academy exam, certification exam. So the European Academy is conducting a certificate of excellence exam, which is conducted every year. And over past 6 or 7 years, we have seen that more and more number of people, more and more number of allergists and our colleague, they are now trying to appear for this exam. But we have realized that there are no structured training pathways that how to appear for this exam, and that is why we have now come up, and I'm now going to announce something new. So we have now come up with a new training initiative, which is 3 months initiative, and I'm just going to share with you. Just have a look. So we are now going to have this 3 months online intensive allergy review program, which will also be called as allergy board review program. Yes.
Very
So if you just,
nice.
so this will be by Allergy School, and you know that Allergy School is an academic part or academic branch of ISAS. So what we are going to do is that we are now going with this certification program, which will be starting or commencing from July first week. So it will be for 3 months, July, August, and September. And we all are aware that in mid October, IAKI exam is there. So we are going to start from July first week, and this will be a 19 pre-recorded session program. So it's a 3 month program in which 19 pre-recorded sessions will be there, and there will be 7 sections. So 7 sections will be organized in a way. So all the topics, all the content has been taken from the IAKI exam point of view. So we all will be dealing now that how to appear for the exam, how to appear for the multiple choice questions, how to appear for the true false questions, different choices. So we will be now switching the gears from, you can say, like from an allergist to a qualified allergist, or we are now looking for the international standards. So this program is of international standard, in which we'll be covering different sections including basic and clinical immunology, allergens and diagnostics, then skin and mucosal allergy, respiratory ocular allergy, systemic allergy and hypersensitivity, spatial areas and immunotherapy, and advanced clinical immunology. So all these sections have been given the weightage in a way in which the same weightage, like the percentage which has been mentioned in IAKI. And so we have now come up with this. And if those who are interested, they can just click this link. They have to just fill up a form, submit the fee, and then direct entry will be there. So we are not, because it's an online program, so it's so easy that you can just sit at the comfort of your sofa or your clinic or your home, and then you can just now read, understand. So this will be pre-recorded sessions, 19 pre-recorded sessions, and then 7 interactive sessions will be there, and we will be taking some MCQs. We will be taking some K-Prim, that is true false questions also, case-based learning also. So it will be exactly at the level of IAKI and even the American board review exam. So we are now starting that, and we are going to also answer each and every option that why this is not correct. So it's not only the correct option, why it is not correct. So we are now going to go from the basics of allergy. We are switching gears, and now for the first time in the country, we are starting this. So I am announcing it in front of, I think, Dipti ma'am. So she is the right person and the most learned person with us. And Dipti ma'am will be one of the faculty along with the other faculties in this particular course. So I would like to invite all my friends, all my colleagues to join hands together. And thank you so much once again, ma'am.
I would
For
like to congratulate you, Dr. Neeraj Gupta, for doing this, taking this initiative. It is one of the best things that has ever happened in our country for allergy. Wonderful initiative. I really, really congratulate from the bottom of my heart.
ma'am,
Great
this
going.
everything is just
Very
like a
nice.
team effort, and I personally feel that I am so much blessed to have a good team, good people like you with me, and that's why everything is happening, ma'am. So thank you for all your support, and
Thank you for those kind words.
troubling, ma'am. We will keep you troubling. So
Sure, sure.
thank you so much, ma'am. Thank you.
Okay. Thank you, Dr. Neeraj, for having me. Thank you. Okay. Bye.